everyone. My name is Madi. I'm one of the medicine chiefs this year. Good morning and welcome to this week's Department of Medicine Grand Rounds. Before we get started, just a few housekeeping tips. Please make sure that your video is off and your mics are muted. Also, we ask that you hold your questions and comments until the end, at which time you may unmute yourself or put your questions in the chat box. Lastly, the CME information today will be displayed on the second and last slide of the presentation. Today, we have two speakers, Dr. Damali Campbell and Dr. Lisa Gittens, joining us from Rutgers Department of Obstetrics and Gynecology for a presentation on maternal morbidity and mortality in New Jersey and the U.S. So briefly, Dr. Campbell is a physician who's certified in both obstetrics and gynecology and addiction medicine. She completed her training at Mount Sinai School of Medicine, Jersey City program. For almost 2 decades, she has dedicated her practice to improve the care of women in underserved areas. Through her clinical and scholarly work, Dr. Campbell has worked on initiatives to decrease preterm labor rates through implementation of group prenatal care, improving breastfeeding rates, improving gynecological care for HIV-infected women, and improve general care for women with tobacco and substance use disorders. Since 2007, Dr. Campbell has been a committee member of the New Jersey Maternal Mortality Review Committee, and since May of 2020, she has been serving as the Executive Medical Director for the New Jersey Maternal Care Quality Collaborative in the New Jersey Department of Health. Our second speaker, Dr. Lisa Gittens, is practicing as a maternal fetal medicine specialist. She completed her training at Rutgers, New Jersey Medical School, and she serves as the Director of Obstetrics and as the Department Patient Safety Officer here at University Hospital. As Director and researcher, her focus has been on implementation of nationally recognized perinatal safety bundles and initiatives and development of new models of patient care, including novel interdisciplinary programs that focus on pregnancy as an opportunity to address long-term disease prevention and racial disparities. Lastly, she's a trustee of the New Jersey Partnership for Maternal and Child Health and an advisor to the Greater Newark Healthcare Coalition and the New Jersey Prematurity Prevention Initiative. So without further ado, we want to welcome both Dr. Campbell and Dr. Gittens today for joining us to give this presentation on maternal morbidity and mortality in New Jersey and the U.S.
Thank you so much for having us. We're happy to be here and happy to start this conversation on how we can be collaborators. So I'll stop a minute here just to focus on some of the objectives that we hope to accomplish today to give you a better understanding of the national data on maternal mortality and morbidity, understand some of the racial disparities that we see, understand some of the national and local data on maternal morbidity and how that's related to hypertension, preeclampsia, and cardiovascular disease. And then we really want to talk about some opportunities to reduce maternal morbidity in the postpartum period through establishment of interdisciplinary coordinated systems of care. And so there's your CME information, and we hope that you'll stay through the remainder of the presentation. So first off, it's important that we start out with some clear understanding of definitions. And so the CDC defines maternal mortality as a death of a woman during pregnancy or after the end of a pregnancy for up to 365 days. And in New Jersey, we review each of these cases where the pregnancy ended either by birth, by miscarriage, by ectopic pregnancy, or by elective termination of pregnancy. And so as you can imagine, even with all that we do, these numbers are likely still underestimated. And it's really important when the committee reviews these cases to determine after the case is abstracted by nurses, whether the death is related to a pregnancy cause, which we define as a pregnancy complication, or a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy, or whether that death was from a cause that was not related to pregnancy, and that would be a pregnancy-associated death. So we really see that all deaths that occur within 365 days are pregnancy-associated, but we really are trying to look at those that have either were caused by pregnancy or aggravated by pregnancy. And another key determination is preventability. Almost 2/3 of maternal deaths are thought to be preventable. Pre-COVID, there had been a fair amount of attention brought to the fact that despite our relative wealth and resources in the United States, that we still have a very high maternal mortality rate when compared to other industrialized nations. And in addition, we have wide disparities of care in that non-Hispanic Black women are found to be 2 to 3 times more likely to die than their non-Hispanic white counterparts in the US. That same national data set shows maternal deaths are on the rise. In 2018, there were 658 maternal deaths, and in 2019, there were 754 maternal deaths. That same data set shows that maternal mortality was rising in total, also for non-Hispanic white women, as well as non-Hispanic Black women. And when we look at maternal mortality by age, we notice that women 40 and over have a significantly higher mortality rate. So what about our New Jersey mothers? We do know this is information from that was released as a part of our New Jersey report card for maternal hospital care. And there was age and racial diversity amongst New Jerseyans. About 25% were 35 and older. 13% were non-Hispanic Black women. And about a third of delivery hospitalizations were paid for by Medicaid or charity care. And this is the same data, most recent, and it's the same information. It has leveled out. There's no difference in 2018 and 2019. So when we want to look at the causes of the leading causes of pregnancy-related death among New Jersey women, we can see that the leading causes are hemorrhage, cardiovascular conditions, infection, preeclampsia or eclampsia, conditions related to that, as well as cardiomyopathy. Sadly, in New Jersey, our racial disparities are worse than those that are seen nationally. Up to 7 times, Black women are up to 7 times more likely to die than their white counterpart. And these racial disparities have existed for quite some time and have been persistent. When we look at the timing of New Jersey deaths, 54% occurred between 43 days and up to a year after pregnancy. And this tells us that just educating OB providers about these issues is not going to help us move the needle to change outcomes as much as we would like. So there's a significant opportunity where non-obstetrical clinicians may encounter recently pregnant and postpartum women who continue to need our care. I wanted to emphasize the importance of timely data and review of these cases. And this is just, if this data is not published, but it is more recent data from 2020 to 2021. And you can see of all the identified cases and the pregnancy-related cases, the top causes of death. And the reason this is important is because we can see some themes emerging, and we're going to need to think about how we're going to have to quickly change our strategies. And so again, under pregnancy related, we still have hemorrhage and cardiovascular conditions, but under all cases, we have drug intoxication, cancer, and then cardiovascular conditions continue to lead the pack. I wanted to remind us that maternal mortality is just the tip of the iceberg when it comes to maternal health, and that unfortunately morbidity is 10 times more common and obviously can result in long-term consequences as well as post-birth trauma. As I alluded to earlier, in New Jersey, we have significant disparities. Black women are several times more likely than non-Hispanic white women. And even those Black women with higher socioeconomic status were more likely to die than their non-Hispanic white counterparts. And so as clinicians, we all are working in a majority minority population. Addressing these disparities is embedded in the fabric of our mission, our teaching, and our clinical practice. And so we know treating everybody the same is not enough. But we need to look closely, and we may need to give different patients more in order to help them to get what they need and to face their unique and individual challenges that they may have. But ultimately, we want them all to be able to achieve an optimal outcome. Childbirth is a condition, not a disease. And for decades, women gave birth and they had a lot of extended support and family that assisted. Oftentimes, nowadays, after women give birth, our attention quickly focuses on the baby. And that's not only from medical personnel, that's from society. And we spend much less time reinforcing health and well-being of the mother. And sometimes moms might complain of not feeling well or having the worst headache of their life, and they may be told not to worry. They just had a baby. And some of the tragic outcomes we see really just have to do with us not listening, not only as medical providers, but even as society. Some of you may have heard about Tara Hansen and the Tara Hansen Foundation. And, Tara Hansen was a woman who sadly, her story was one of those stories that led to, in New Jersey, the legislation for Maternal Health Awareness Day, 1, 2, 3 for moms. And that we just celebrated Maternal Health Awareness Day, January 23rd. Some of you also may have heard the story of Serena Williams, or the story of Kira Johnson, who was the daughter-in-law of one of the TV judges. And sadly, these cases are not enigmas. But today, our mothers face a variety of different circumstances. But this particular campaign from the CDC reminds us, and there's not only patient-facing material, there's provider-facing material, and there's also community-facing material, but it just reminds us to hear this woman's concerns, hear her concerns. And so we call this the Hear Her campaign. And again, I can't overemphasize the importance that all birthing people need to feel seen and heard. And this is just a pictograph from an organization called the National Association to Advance Black Birth. And so as we raise awareness about maternal health, we want to make sure that we are listening to our mothers. So again, nationally, 33% of pregnancy-related deaths are occurring 1 week to 1 year after delivery. And it's the under-recognition of these risks and their timing that contribute to poor outcomes and even death. And so from a medical perspective, a public health perspective, and even legislatively, there's an opportunity for us to make some change. I did not want to forget to just mention that the underlying cause of death does vary based on race. And so depending on where you're practicing, I know here in Newark, New Jersey, we have a majority minority population, but depending on where you're practicing, these causes of death may differ by race. I wanted to tell you that in New Jersey, legislatively, the current administration has been a real champion, particularly through the First Lady, Tammy Murphy, and the governor has signed several pieces of legislation to promote maternal health, particularly the initiative that I work on is the second one, PL 2019 C75, that established the New Jersey Maternal Data Center, the New Jersey Maternal Mortality Review Committee, and the New Jersey Maternal Care Quality Collaborative. And the purpose of the Quality Collaborative is really to take the data that is gleaned from the Maternal Data Center and the data that's gleaned from the Maternal Mortality Review Committee to really talk about the programs that we need to improve the health and outcomes for New Jersey mothers. Another more recent piece of legislation that was signed by the governor is one to offer nurse visits after birth to address, because we know so many women go home. Again, there's a lot of focus on the baby, and many times mothers don't oftentimes make it to their postpartum visit. And so this initiative to offer nurse visits after birth, home visits to the mothers, is in an effort to help address this maternal mortality crisis. So our partnerships are key, and we'll talk a little bit more about those partnerships as we get further into this discussion. From a public health perspective, it's important that we improve our clinical care, but we also need to improve our public health infrastructure. We need to improve our community supports and the network of our communication. I'm going to hand it over to Dr. Gittens now, who's going to discuss some more about the leading causes of morbidity and mortality. And then we'll talk about some of the innovative strategies that we have from a clinical standpoint to improve the care of mothers. And I'll stick around for questions at the end.
Thank you, Dr. Campbell. Can everyone hear me? So you have seen and heard the grim facts. There's a rising national maternal mortality rate that is now 20 per 100,000. And there's a doubled maternal mortality rate for Black women, 44 per 100,000. And what's really striking to me and taking care of my patients is the high maternal mortality rate for women over 40 at 41 per 100,000. So I'm here to provide you with some evidence of where we can seek opportunities. We've long known that hemorrhage and thromboembolism were leading causes of maternal death worldwide. This slide shows you some CDC data for pregnancy-related deaths. And I bring to your attention the first column, the high rate of cardiovascular disease, 15%, but also cardiomyopathy in the third column, and cerebral vascular accidents, and then hypertensive diseases of pregnancy or disorders of pregnancy at 6.6%. This demonstrates that if we really focus on cardiovascular disease, we can provide great opportunities for intervention. Next, please. The Alliance for Innovation in Maternal Health, or AIM, is a national data-driven maternal safety and quality improvement initiative, and AIM works with state and community-based teams to align national, state, and hospital quality improvement efforts. So in response to the maternal health crisis, AIM developed patient safety bundles, which are evidence-based interventions that can improve maternal health. The AIM Hemorrhage Bundle, for example, provides a roadmap for organizations to quickly respond to maternal hemorrhage by encouraging teamwork, rapid access to medications, and a coordinated response. The AIM Hypertension Bundle requires that organizations have a standard response to maternal hypertension, thus allowing quick action to reduce the risk of death. In 2017, through the New Jersey Perinatal Collaborative, New Jersey signed on to be an AIM state, and these safety bundles are implemented at birthing hospitals throughout the state. In 2020, the Joint Commission also implemented a requirement for organizations to have standard response to hypertension and hemorrhage, thus aligning with the AIM recommendations. So at University Hospital and other hospitals, there are policies and processes that dictate the management of severe hypertension in pregnant women. Next, please. Next slide. The case for a standard response to maternal events is actually clear. This slide shows data from Dr. Elliott Main in California, and they looked at the leading diagnoses associated with maternal death on the bottom, and then some drill down data from their maternal mortality reviews on the causes. And it was clear that delayed response to clinical warning signs and ineffective care were major causes, and you can see that in the blue and then in the red. We call these the deadly Ds: denial, delay, and dismissal. And so the implementation of safety bundles can address this. Next. With a focus on hypertension, the Joint Commission requires that organizations educate and implement standard protocols for monitoring blood pressure. And so organizational training is required. And you'll likely hear more about this as technicians throughout the hospital, nurses, and those who take blood pressures will be required to understand how to measure blood pressure in women. Next. Simple things like assuring proper placement of the blood pressure cuff, cuff size, and maternal position are key in this bundle. And then rapid response when blood pressure is elevated is also part of that. Next. The Joint Commission also requires that patients and family members are educated throughout their hospitalization about postpartum risks. So one tool that's used throughout many organizations is this post-birth warning document, which is in simple language, educates patients to call 911 if they have symptoms such as chest pain, difficulty breathing. And again, education of the family members is very important because in the postpartum period, the focus is typically on the baby. Next. Traditional follow-up for mothers after delivery has long been 6 weeks postpartum. But national rates of postpartum follow-up, that is, in the ambulatory setting, are really under 15% for Medicaid-insured populations. In this study, identifying data from over 200,000 deliveries in 21 states, Dr. Stephen Clark looked at the timing of postpartum maternal emergency room visits. And the study demonstrated that most mothers were returning to the emergency room within 7 days of their delivery. But then morbidity continued throughout up to 99 days in this study, demonstrating that if we saw patients at 6 weeks postpartum, we would miss most of the problems that they were having. Next. And this study demonstrates the timing and reasons for the ED visits. And you can see that patients were coming back for life-threatening issues such as hemorrhage, infection, but also eclampsia and heart failure. Next slide. And so this information caused a paradigm shift in the way postpartum care was administered. The American College of Obstetrics and Gynecology began to recommend an earlier postpartum visit that was at 3 weeks, and they promoted the concept of the fourth trimester, recommending that care be provided for 3 to 12 weeks postpartum. ACOG recommended that there would be an addition of a comprehensive healthcare visit to address long-term and lifelong health risks, and thus promoting the intersection of pregnancy and pregnancy complications with long-term health risks. Traditional Medicaid programs typically terminated coverage after 8 weeks postpartum, thus reducing the opportunity for women to get any type of long-term care or transition to primary care providers. We are very fortunate that now New Jersey is approved for a Medicaid waiver, which expands Medicaid coverage to 1 year postpartum, and that provides us with great opportunity for care transitions. The Center for Disease Control and Prevention has designated the diagnoses that are listed here as severe maternal morbidity. And severe maternal morbidity is defined as unexpected outcomes of labor and delivery that can result in short or long-term consequences. So these are events that can be associated with maternal death, but they're also associated with morbidity. So just as national rates of maternal death are now being reported, the focus on severe maternal morbidity is now high because these events, if they occur and they don't result in death, we can think of them as near misses. So some of the indicators that the CDC uses for severe maternal morbidity include things like renal failure, cardiac arrest, eclampsia, the need for a hysterectomy, temporary tracheostomy, pulmonary edema, and you can see acute heart failure there. New Jersey now publicly reports aggregate severe maternal morbidity data annually by hospital in the New Jersey Maternity Report Card. But this report only tells us when these events occur at the time of birth. What we don't have good data on is when severe maternal morbidity occurs in the postpartum period after the patient has left the hospital. Next. So let's take a look at who's more likely to have a severe maternal morbidity event. This study looked at 569,000 women who delivered in New York City. They found that women with hypertensive disorders of pregnancy had a higher rate of severe cardiovascular morbidity compared to normotensive women. And the risk of a cardiovascular morbidity progressively increased as the hypertension became more severe. And in fact, in this cohort, there were 15 deaths, and 14 were related to cardiovascular morbidity. Next slide. So these investigators in a JAMA Open Network publication in 2021 evaluated causes of severe maternal morbidity at the delivery episode, and they compared them to severe maternal morbidity in the postpartum period in a Medicaid-insured population. And what's striking about this is that heart failure is at the top of the list for severe maternal morbidity in the postpartum period, providing an opportunity for intervention. The timing of postpartum severe maternal morbidities are similar to the timing of ED visits. Most occur within that 1 week postpartum, but a significant amount can extend out beyond, up to and beyond 42 days. As we drill down on, next slide please. As we drill down on heart failure, we can see that in this study by Dr. Aziz at Columbia University, using nationwide readmission data identified by the CDC criteria in a cohort of 1 million women who were readmitted, 47,000 of these women were Black, 33,000 were Hispanic, and 94,000 were white. So a very high rate of readmission for Black women. But when looking at the reasons for readmission, Black women identified in the blue had significantly higher rates of admission for pulmonary edema and acute heart failure. Next. So the need to focus on cardiovascular disease is apparent. It's a leading cause of maternal mortality in the United States. It's under-recognized in pregnant and postpartum women, and it's higher in African American women. And 25% of the deaths that are attributed to cardiovascular disease might have been prevented if the women's heart disease had been diagnosed earlier. So we see pregnancy as a period where there's a great interaction with healthcare providers, and it gives us that opportunity to detect and treat heart disease, improve pregnancy outcomes, and affect future cardiovascular risk. And I am truly personally hoping that the New Jersey Medicaid expansion has a great opportunity for us to improve maternal cardiovascular outcomes. Next. So Dr. Campbell reported to you data from 2014 to 2016 with cardiomyopathy being a leading cause of maternal death in New Jersey. This slide is from data in California, and they did an intensive analysis on maternal death from cardiovascular disease. But the key points, 30% of cardiovascular diseases deaths were occurring more than 42 days postpartum, and 42% of cardiomyopathy deaths were more than 42 days postpartum. Again, emphasizing the need for better care outside of the pregnancy window and beyond the 6 or 12, even 12 weeks where the obstetrician might see the patient. Next slide. So the hypertensive diseases of pregnancy are defined as gestational hypertension, chronic hypertension. And so these investigators looked at the association between the hypertensive diseases of pregnancy and severe maternal morbidity in a Medicaid insured population. And the cohort was in inner city and minority women. Interestingly enough, in this cohort, 38% of women had a hypertensive disorder of pregnancy. And that's a really high rate of hypertension complicating pregnancy, because nationally, the rate of hypertension complicating pregnancy is about 6 to 8%. It's possible that here in University Hospital in the city of Newark, we are seeing similar rates of hypertensive disorders of pregnancy. But in this cohort, women who had a hypertensive disorder of pregnancy had a double the risk of severe maternal morbidity. So this speaks to the degree with which hypertensive disorders of pregnancy contribute to severe maternal morbidity. The authors recommended that in populations where the rates of hypertensive disorders of pregnancy are high, aggressive attention to management steps is the first way we can reduce severe maternal morbidity. Next slide. And to further assess the contribution of hypertension to maternal mortality, this recent study published by Dr. Anath and colleagues from Robert Wood Johnson, they evaluated trends in maternal mortality due to chronic hypertension, gestational hypertension, and then preeclampsia, eclampsia. And over this time period, they reported that Black women were 2 to 4-fold at an increased risk for hypertensive-related death compared to white women. They also found that mortality from preeclampsia actually declined during this period, but chronic hypertension-related maternal mortality increased dramatically by 9.2% annually. So while we're better at managing the complications of preeclampsia, eclampsia, perhaps in the hospital setting, strategies to reduce overall hypertension related to maternal mortality require our attention. So this means to me that we need to focus on inter-pregnancy care, on cardiovascular risks, better blood control, and then managing diabetes and also obesity. Next slide. So the long-term outcomes of hypertensive disorders of pregnancy are fairly well defined, but women often don't know these risks, and they might not be discussed by a provider or even when she returns to her primary care provider. So the 4th trimester follow-up allows for us to transition to primary care, internal medicine, cardiology, or other professionals who understand pregnancy-related risks. And it's clear that women who have a hypertensive disorder of pregnancy have a 12 to 25-fold higher rates of hypertension than normal-tensive women in the years to follow. And of course, there's an increased risk of end-stage renal disease, stroke, and dementia. And so this information needs to be more widely spread to pregnant women. Next slide. So what should hypertension control be? We know that the American Heart Association and the American Cardiology Association have set goals for blood pressure for non-pregnancy as 130/80. And this can be confusing because among pregnancy experts, there is not consensus as to what the optimal blood pressure should be during pregnancy. There's not agreement on how tightly blood pressure should be controlled. And you can see here some data from the varying organizations, one ACOG, and then some international organizations where the goals for pregnancy blood pressure control really vary. And so that also can be very confusing to providers. The thought is that during the pregnancy, blood pressure control should not be so tight so that you can allow for perfusion and fetal growth. And one of the largest clinical trials showed that tighter control was associated with a reduction in progression to severe disease. And that's likely why many of the international organizations have opted for tighter control during pregnancy. But what's key is that in the postpartum and interpregnancy interval, women with hypertensive disorders of pregnancy are an important group who require primary care management. So women with preeclampsia are really at twice the risk of developing long-term hypertensive disease, cardiovascular disease, renal disease, diabetes, and premature death in their later years. And so it's further increased when they have recurrent preeclampsia and also early onset preeclampsia leading to preterm birth. Early onset preeclampsia is very interesting because in the past, early onset preeclampsia was managed by delivering the mom. But now better understanding about how we can prolong the pregnancy has led to practices where even early onset preeclampsia, unless it's severe, is managed expectantly, thus exposing this woman to the preeclamptic milieu. And I'll talk a little bit more about how that might be causing some of the problems that we see. But women with histories of hypertensive disorders of pregnancy should be referred to primary care providers, and they should have 6 months to 1 year postpartum follow-up to evaluate for cardiovascular disease. Next. So the American Heart Association and the American Stroke Association are in agreement with this. Women with histories of preeclampsia and eclampsia, that should be elicited in their history, and they should be followed throughout their life cycle. Clinicians should be aware of the association between these adverse pregnancy outcomes and cardiovascular disease and stroke. And we really need to share this information and these resources with patients and their family and have them adapt lifestyle changes like weight management, increased physical activity, smoking cessation, lipid control, when we see that the pregnancy hypertension is a risk factor for these long-term problems. Next. So although the obstetrical community continues its debate and thinking about the degree to which blood pressure should be controlled in pregnancy, it's well established that women with preeclampsia are at risk for these long-term cardiovascular outcomes. So gestational hypertension is thought to increase the risk of cardiovascular disease by 67% and also to increase the risk of stroke by 83%. And so preeclampsia is thought to generate this persistent and subtle anti-angiogenic milieu, which may contribute to lasting endothelial dysfunction and increase the risk for cardiovascular disease in women. And the pathogenesis is really nicely explained in this graph or model for the pathogenesis, I'd like to think. If you look at this image in the red, this is women who have had preeclampsia. And so they have a higher vascular risk, which is on the axis here, the y-axis. And so after 2 pregnancies, the bumps represent pregnancies. So after 2 pregnancies, that patient will have a greater lifelong risk of cardiovascular disease. And the blue represents someone who doesn't have a hypertensive disorder of pregnancy. It suggests that pregnancy itself increases their cardiovascular risk, but not to the same extent as does the preeclamptic or hypertensive disorder of pregnancy episode. So this is a model of thinking about the hypertensive disorders of pregnancy and their relation to cardiovascular risks. And so in the modeling for this, the thought is that it's the disruption of the vascular homeostasis or placental dysfunction that characterizes preeclampsia. And that endothelial damage in multiple organs, including the vasculature, puts these women at risk for cardiovascular disease. And as I said, altering the management of preeclampsia and allowing for this environment to exist in a expectant management state to improve neonatal outcome may well be contributing. But we need a lot more information on the exact science of why this is happening. Next slide. Next, please. Next slide. So it's important to remember, I'm sorry, you can go back. You can go back. Right, that's fine. Thank you. So it's important to understand that pregnancy complications that lead to the long-term cardiovascular risks. And so in addition to gestational hypertension and preeclampsia, there's also gestational diabetes is thought to influence this risk, and preterm labor and preterm delivery, and also the state of placental abruption. All of these may have some common inflammatory anti-angiogenic relationship to their causing long-term cardiovascular disease. Next. So obstetricians are fully aware of the maternal consequences of the hypertensive disorders of pregnancy, and we know that they can lead to death, increased risk of cesarean delivery, hemorrhage, stroke, myocardial infarction. And we're also fully aware of these fetal risks, growth restriction, preterm delivery, and congenital anomalies, stillbirth, birth, and neonatal death. Next. But again, what's less known are the mechanisms between the relationship between all of these hypertensive disorders of pregnancy and other cardiovascular risks that are unique to women. And so, the evolving science on this will give us more information about how to come up with interventions. Next. So we can only reduce the risks of complications after pregnancy if we're identifying patients as postpartum and we have robust programs for postpartum follow-up. So keep in mind that most complications occur within 7 days, up to 42 days, and then beyond. So it's very important to understand who is postpartum. In this study, they looked at over 1 million women in the postpartum period, and they demonstrated that 15% were admitted to a hospital that was different than the delivering hospital. And so it's really important to recognize that when patients come to the emergency room, you have to ask if they're postpartum, and then you have to get the pregnancy history. If you don't know that they had a hypertensive disorder of pregnancy, you may not know that they have a risk for cardiomyopathy or other pregnancy complications. Fragmented care is one of the things that leads to high rates of maternal death. And likewise, when patients present to a primary care provider after their pregnancy, we have to ask them what the pregnancy complications were. Next slide. So some innovative ways to counsel mothers about postpartum risks are done in simple infographics. The most important key points are to remind mothers that it's a myth that pregnancy problems go away after pregnancy. All problems don't go away. So hypertension and diabetes especially don't go away after the baby's born. And that's something that we need to make sure that patients understand, and then the providers that are taking care of them after they deliver also understand. Advising about blood pressure control, this infographic, I don't know if you can see in the blue box, they're specifically advising patients that optimal blood pressure control after delivery in the postpartum period is 120/80. This is challenging for patients because we have different metrics during the pregnancy, and then we have different metrics in the postpartum period. And patients are resolving their pregnancy physiology in the few weeks after the delivery, making it challenging for them to understand what optimal blood pressure control is. So we see many women who don't have a physician, and they start their pregnancy where the hypertension is not being managed to this level. Next. So again, using these types of patient education materials, we can begin to help women understand that they're at risk for heart disease, and then they can carry this information on to their primary care providers. These infographics came from California Quality Collaborative, but the same is really required and necessary in New Jersey, particularly where we have such high rates of maternal hypertension. Next. So we're going to move on to the next slide. You can move on. And talk about how we can have better medical care. Dr. Campbell, do you want to join me?
Sure. Yeah. So again, we saw this as an opportunity to talk about how we can better collaborate and also some innovative models. And so, you know, I think one of the things that we're thinking about is how to structure having warm handoffs to primary care providers in cases where patients have gestational hypertension or preeclampsia or a variety of different pregnancy complications, or just need chronic management of some of their chronic illnesses. Oftentimes I will see patients who may have not seen a provider since they were teenagers, and they have asthma that they have not had well managed. So you know, we need to think about within our system of care how we can have some warm handoffs. And then we also want to think about new models of care. And as Dr. Gittens mentioned, obesity management, particularly since obesity is related to cardiovascular disease and diabetes. And again, just management of chronic illnesses. And I think Dr. Gittens mentioned about insurance coverage, which has been such a huge issue because many of our pregnant women have only had insurance during their pregnancy. And so if their insurance ends 6 weeks postpartum, then we were seeing so many times that they didn't have the insurance to go to PCPs, to medical providers, or to have this follow-up care. So we are really hoping that this Medicaid expansion and legislation that allows women to have care, to keep their insurance for a full year postpartum, is going to make a difference in a lot of this.
So,
go ahead, Dr.
I'll jump in so that, you know, some of our models that we've looked at, we did a centering for diabetes and obesity. So centering is a group model of care. We did that pre-pandemic. It was very successful. We partner with grocery stores and, you know, community doctors. And in those kinds of models, we'd like to transition our obese patients to weight loss doctors. And that could be in the Department of Medicine, so that we can have these patients recognize the importance of losing weight to reduce their cardiovascular risks. Our own data published by one of our maternal fetal medicine fellows showed that, you know, in pregnancy, we were able to decrease patients with diabetes, their hemoglobin A1C, very nicely, so that at the end of the pregnancy, we were reducing the risk to the neonate. But in fact, when those same patients came back for another pregnancy, the A1C was back up 9, 10, 12. So again, we need better inter-pregnancy care for these women with diabetes. Other types of partnerships we have is that we've partnered with community partners to get durable goods. So we're able to give patients blood pressure machines to go home to reduce their risks of hypertension in that severe hypertension in the immediate postpartum period. But again, we need better transitions of care, and we need tighter management of hypertension in the inter-pregnancy interval.
And so, you know, another innovative model is this one that was actually initiated within your department, within the Department of Medicine, as a joint venture between internal medicine and preventive medicine. And that's the 4-year program with a maternal health focus. So I'm sure I know I see some familiar faces on the call. So many of you may be aware, but for those of you who are not, This was a primary care training and enhancement community prevention and maternal health grant given by HRSA. And so Dr. Gittens, myself, and Dr. Roche are actually working with Morella and Dr. Thomas and Emily Gordon, as well as thought leaders from the School of Public Health and the VA to have this joint program where, some of our colleagues who are internists will have additional time to focus on maternal health. And we believe that, this is going to be key to have more internists, more family practice, more primary care providers who have a better understanding and interest in maternal health that obstetricians will be able to hand off to. So this is just one initiative, and there are many, many more, including the ones that Dr. Gittens mentioned. And Dr. Gittens, I don't know if you want to add anything else here.
No, just that I'm really excited about this program. I'm really excited whenever I get a call from members of your department or your team asking me about, maternal health, because this is really a crisis. And I recognize that, in taking care of people throughout their lifespan, as internal medicine providers do, there can be a great focus on the elderly with so many complications. And so young women with hypertension, given that they don't necessarily have so many other comorbidities, that can be a lower on the list thing. But for those critical care people who work with us, when these mothers crash and when they have cardiomyopathy or when they end up in the ICU, you can see that, pregnant women they're fine until they fall off the cliff. And so, and trying to save them can be so challenging. So I really look forward to this collaboration and being able to hand off these patients so that they can get better long-term care. And I'm excited for the governor for having opportunities so that we all get paid to do it. So I think we can take any questions.
Yep. So I'm going to
start. So first, let me, hi, it's Dr. Clapples here, and let me thank you, Dr. Gittens, Dr. Campbell, for this really terrific presentation, rather sobering presentation of what's going on in maternal health in the country and here locally, and especially with the African-American community and the women that we take care of in our institution here. I really want to thank you for bringing this to attention and highlighting the opportunity for collaboration. And I want to maybe get a comment because I think I'm going to comment Dr. Ferdinand, Dr. Thomas perhaps, and we're very excited about this new internal medicine, preventive medicine residency program, which folks who match into that program are both eligible in preventive medicine and internal medicine and 4 years of training to get a master's in public health as part of that. And this partnership with you and this focus of that program on maternal health. So, I really appreciate it that much more, I have to say, and I hope everybody who's with us on this presentation this morning really do appreciate it much more. And maybe Dr. Ferdinand and Dr. Thomas, want to just comment for a minute? And I also want to come back also to a conversation with our Med-Peds colleagues, which we have also in the Department of Medicine, which also should be a very rich opportunity for collaboration. But first, Dr. Ferdinand, Dr. Thomas.
I know I'm very excited about this new collaboration with GYN. We're looking forward to perhaps creating a women's health clinic that all the residents would benefit, in addition to the training for the combined track residents. Really excited to grow together this project that came actually out of an idea that Dr. Clapples had.
And we're inspired by the public health. We're inspired by the public health focus of our obstetrics department. Dr. Campbell, Dr. Gittens, and Dr. Roche have been, they are just so innovative, and we are very honored to be joining them.
Yeah, thank you. Thanks very much for that. And this is really just, it's been, I think, kudos to yourself, Dr. Thomas, Dr. Ferdinand, for getting this done, really. And Dr. Wang, I think I saw Dr. Wang was on, and from Med-Peds perspective, there would seem to be opportunities to provide the maternal care while also providing the child care. What do you think about that?
Yes, absolutely. We definitely see moms and their babies coming into our clinic for the newborn visit, and we have a lot of touch points with the families early on. We typically see the newborns within the first week of life, and then at a month for a weight check, and then at their 2-month visit for their shots. And I always felt like it was a great opportunity to also see mom in that critical period where some of their other primary care services do get just dropped off. They're very focused on caring for their baby as opposed to themselves. So absolutely, I think this is a great connection and collaboration. And I know Natalie Seuss is looking forward to her meeting with Lisa. So we definitely look forward to collaborating with the group in the future.
That sounds great. Appreciate that, and really opportunity to protocolize, as has been talked about with Dr. Gittens, Dr. Campbell, about really protocolizing some of that care so we don't miss things. Other comments, questions, or anything else, Dr. Gittens, Dr. Campbell, or anybody else in the audience for comments or questions?
I just wanted to comment. I recently had a woman who was hypertensive postpartum, and the GYN docs were managing her blood pressure meds. Is there a time period that you would suggest? Because I think it's bad to have 2 different doctors managing the meds and the pressures. Do you think 6 weeks or 3 months or right away? What's the ideal transition time?
Yeah, that's a really good question. So typically in our environment, because we're managing these patients with like hypertension postpartum, we see them. The recommendations are that they're monitored for 72 hours postpartum. So typically they're still in the hospital for those 72 hours. Now, pandemic has changed a little bit, and we would follow up with telehealth if we sent them home. But we know that in that first 72 hours, their blood pressure can go up. They can have, they can go from gestational hypertension to preeclampsia. They can have chronic hypertension and have preeclampsia, and they can have severe features. So we're monitoring them for those first 72 hours. Then we send them home, and we're following them up in a week. That postpartum follow-up allows us to see if they really mobilize their pregnancy fluid and if whether or not their blood pressures are still high. We send them home with blood pressure machines. And then after that, we'll probably see them again in 3 weeks. So I think that most of the handoff will happen. I would love to see it happen after that 3-week period where they transition to a primary care provider, but maybe still are also coming back to us to resolve other pregnancy problems, like we're addressing sleep hygiene, we're addressing contraception. But we do need to have that handoff happen in that time period. Another problem is that many of the women don't have a primary care provider. So the first time that they get insurance is during the pregnancy episode, and then they're coming to an OBGYN. If we can identify that primary provider, we can have them manage the hypertension and the meds. So I would say after 3 weeks.
Yeah, I just wanted to bring a point about doing all this before the pregnancy occurs actually will help more the morbidity and mortality in both mother and child. We see a lot of patients with diabetes and obesity, and we kind of prepare them if they want to get pregnant to have better control of their diabetes before they get pregnant so that they have better outcomes. Same thing with the hypertension. And I think having the nutritionalist and endocrinologist managing obesity, hypertension, diabetes pre-pregnancy will improve the maternal morbidity and mortality in these patients and cardiovascular risk.
Absolutely. So in our women's clinic, our forthcoming women's clinic, the preconception counseling can take place. And so women of reproductive years, even if they just see an obstetrician and understand what their risks are and how the pregnancy is going to go and what things might happen, and they understand that this is putting them at risk for prematurity and other complications to the baby, because women will do anything for a baby. It's biologic, it's a protective factor. And sometimes once you tell them, you can see that they'll get that hemoglobin A1C under control. So I really appreciate that comment. And I really look forward to having that interpregnancy interval or preconception period managed with us working together.
Dr. Gittens, so thank you very much again. And Dr. Campbell, thank you also very much again. And unfortunately, our time is up. I also want to just quickly just note as well is that there is an opportunity here as well on the cardiology side. And given what you have brought to the table here, I think we really need to take another look at that in our ability to collaborate with you and within the department around perhaps earlier cardiovascular intervention. We have a very strong heart failure program, so we'll take a look at that again as well. And I want to thank you again for this really wonderful presentation and to really that highlighted this really incredible need and opportunity that we have to do a better job in taking care of these moms and delivering better maternal health care. I want to thank everybody for joining this morning and hope that you learned as much as we all did. And again, thank you to Dr. Campbell and Dr. Gittens for this wonderful presentation. Wish you all a great rest of the day. Thank you.
Thank you so much.